When we think about healthcare, a lot of us worry about just being able to get to a doctor. But what if that's not even half the battle? What if the real challenge is what happens after you walk through the hospital doors? Today, we're looking at India's incredible plan to fix this hidden crisis, and in the process, completely change what we mean by quality healthcare.
Let's start with just one number, a really shocking one, actually. 60%.
Yeah, you heard that right. According to a major Lancet report, a huge majority of preventable deaths in these countries aren't because people couldn't find a hospital. Nope. It's because the care they got when they arrived was just not good enough. This completely changes the conversation. It's not just about building more clinics, it's about making the ones we have work so much better.
So how do we tackle something that big? Well, here's our roadmap. We'll start with the real human cost of this crisis. Then we'll trace India's long journey to find a real solution. We'll break down what quality even means, and then, this is the really cool part, we'll see how they actually make improvements happen. We've got a fantastic case study to walk through, and we'll wrap up by looking at what this all means for the future of public health.
First things first, we need to understand what's really at stake here, because this isn't about policy papers, it's about people's lives. The source material puts it so powerfully. Poor quality care, it's a devastating domino effect. Of course, you have the tragic, preventable deaths, but it goes so much deeper than that. It's about families being pushed into poverty by medical bills, and it's about this slow, corrosive loss of trust in the very institutions that are supposed to heal you. And when that trust disappears, people stop seeking help, and the whole awful cycle just gets worse.
So this is not a new problem, right? And India has been wrestling with it for decades. Let's take a look at the journey to find a single, unified system that could actually work across such a massive and diverse country. This whole journey, it wasn't exactly a straight line. It really kicked off in the late 90s, focusing on specific things like child health. Fast forward to 2007, and you get standards for infrastructure, the buildings, the equipment, but not really for the care itself. By 2012, you had all these different efforts going on, but they were all fragmented. It was like having a bunch of incredible musicians all playing a different song. And then, 2013, this was the game changer. The National Quality Assurance Framework, or NQAS, was launched. This was the moment the orchestra finally got a conductor and a single piece of music for the entire nation.
Okay, so this is a really crucial point. Before you can improve quality, you have to agree on what good actually looks like. What are we all aiming for?
The official definition really boils down to two simple but powerful ideas. One, are we getting the best possible results for patients? And two, are we using the best, most current science to get there? It's all about combining compassionate care with cutting-edge knowledge.
And quality isn't just one thing. It's actually a delicate balance of 6 different ingredients. It has to be safe, first and foremost. You shouldn't leave sicker than you arrived. It must be effective, using treatments that are actually proven to work. It needs to be person-centered, treating you as an individual, not just a set of symptoms. It has to be timely and affordable, so you're not waiting forever or going broke. It needs to be efficient, so we're not wasting precious resources. And critically, it must be equitable. The quality of your care should never depend on who you are or where you live.
Okay, let's quickly demystify some of the jargon you hear. Think of it like making a book. Quality control is like finding a typo in the book after it's already been printed. Oops. Quality assurance is like having a really good proofreader check the manuscript before it goes to the printer. Much better. But quality improvement, that's the real goal. That's like redesigning the entire writing and editing process to prevent typos from happening in the first place. And the genius of the NQAS framework is that it does all three.
So, we've got the history, we've got the definitions. Now for the exciting part. How does this actually work in a busy, crowded, real-world hospital? Let's break down the NQAS framework. At its heart, the NQAS is a beautifully simple engine for change. It's just a 2-step process. First, you measure. You find out exactly where the problems are. Then, you improve. You use a structured, scientific approach to fix them. And then you do it all over again. Measure, improve, repeat. It is a relentless cycle of getting better. So how do you measure quality?
Well, the NQAS gives hospitals a whole diagnostic kit. We're talking detailed checklists, deep dive audits of everything from prescriptions to medical records, and, this is so important, getting honest feedback from both patients and staff. It's all about gathering data from every possible angle to get a crystal clear picture of what's really going on.
And once you know where the problems are, it's time to fix them. And this isn't about guesswork or blame. It's a system. Teams dig deep to find the root cause of the problem. They prioritize what to tackle first. And then they use a clever method called the PDCA cycle, which stands for plan, do, check, act. Basically, they test small, rapid changes to see what actually works before rolling out the solutions that are proven to make a real difference.
Now, this all sounds great in theory, but does it actually work in the real world? Let's take a look at a case study that shows the incredible power of this framework in action.
Let's look at a problem that I think we can all relate to: waiting rooms. A quality team at one hospital found that patients were waiting, on average, 28 minutes just to get registered. That's before they even get in the queue to see a doctor. I mean, what a frustrating start to any hospital visit. So how did they tackle this? Not by blaming the receptionist, but by using this brilliant tool called a fishbone diagram. As you can see, it allowed them to map out every single potential cause of the delays, from the layout of the waiting room to the complexity of the forms to the hospital's own policies. It's a masterclass in systematic problem solving. With this detailed map of the problem, they started experimenting. Using those rapid PDCA cycles we talked about, they tested a series of small, smart changes. They moved the registration desk. They tweaked the opening times. They redesigned the forms to make them simpler. They just put up clearer signs. Each change was a small experiment, designed to see what would make the biggest difference. And here's the result. By following the process, they didn't just make a small dent. They cut the average patient registration time from 28 minutes all the way down to 15. They reduced it by nearly half. That is a real, measurable improvement in the patient experience.
So let's just zoom out for a second and think about what this small victory means for the bigger picture of public health.
The real magic here isn't just about shorter queues. It's about a fundamental shift in mindset. It's the realization that you can transform a vast, complex system not with a single dramatic revolution, but with a relentless accumulation of small, smart, data-driven victories. Each problem solved, each process improved, is another brick in the wall of a better, more trustworthy healthcare system.
And that brings us to a really powerful question. If a simple, structured process can solve a problem as universal as waiting in line, what else can it do? Could this be the key to tackling some of the most wicked problems in healthcare, from hospital-acquired infections to medical errors? This blueprint from India suggests that with the right tools and the right mindset, even the most impossible challenges are just a collection of solvable problems waiting for us to begin.